Approach to patient with headache by Senior Clerk Concepcion. Headaches are among the most common reasons for doctor visits and is responsible for more disability versus other neurological problems. Let us first discuss the science behind headaches. Pain occurs when the peripheral pain receptors, called nociceptors, are stimulated by injury, visceral distension, or any other causes. Headache also occurs when pain-producing pathways are damaged or activated. Pain-producing cranial structures are scalp, meningeal arteries, dural sinuses, falx cerebri, and the proximal segments of the large PL arteries. Here are the structures that do not produce pain. It includes ventricular ependyma, choroid plexus, PL veins, and the majority of the brain parenchyma. To further understand the mechanism for headache, let us discuss the types of headache according to the International Headache Society. We have primary headache, in which the headache and its features is the disorder itself. And we have secondary headache, where there is an underlying cause for the headache. In primary headache, there are key structures that play important roles. First is the trigeminal-vascular system, which is composed of large intracranial vessels and dura mater innervated by your trigeminal nerve. Second is your trigeminocervical complex, which is the caudal portion of the trigeminal nucleus, which extends into the dorsal horns of the upper cervical spinal cord. Third is your rostral processing regions, which include your ventero-posteromedial thalamus and cortex. Lastly, pain modulatory system, which includes your hypothalamus and brainstem structures. This modulates the inputs from the trigeminal nociceptors. When these structures are damaged or not properly functioning, pain is perceived, resulting to headaches. There are also specific features in primary headache, which are called cranial autonomic symptoms. This is a result of the activation of the cranial sympathetic pathway from the pain, which causes vascular changes. This includes lacrimation, conjunctival injection, nasal congestion, rhinorrhea, periorbital swelling, aura, and ptosis. It is important to note that although primary headaches may show symptoms of vascular changes, it in itself is not a vascular event. It is also important to differentiate these symptoms from those of the symptoms of infection, such as URTI. There are several kinds of primary headaches. The most common kind is a tension type with 69% incidence. It is characterized by bilateral tight band-like discomfort without any accompanying features. Migraines, on the other hand, which is the second most common kind of headache with 16% incidence, is defined as an episodic headache with associated features. It also has three phases, namely your prodrome, headache, and postdrome. The simplified diagnostic criteria for migraine states that it should at least have two of the following: unilateral pain, throbbing pain, aggravated by movement, or moderate and severe intensity. Plus, it should at least have one of the following: nausea or vomiting, and photophobia and phonophobia. Idiopathic stabbing headache has an incidence of 2%. It is characterized by stabbing pain, solitary or in series, only on the head or face, lasting 1 to many seconds. It has no cranial autonomic features, and it must occur in the absence of cutaneous triggers. This kind is recurrent but irregular in frequency. Exertional headache has 1% prevalence and is preempted by exertion of force or physical activity, such as a Valsalva maneuver. The rarest kind of primary headache is the cluster headache, with only 0.1% prevalence. It is described as deep, excruciating pain, non-fluctuating, and explosive in quality, located in the retroorbital area, and is usually unilateral. It is periodic, with at least one attack occurring at the same time every day, and this is a core feature of a cluster headache. Here are some of the causes for secondary headache. The most common is systemic infection with 63% prevalence. It ranges from mild URTI to severe forms like meningitis, which is characterized by severe headache, stiff neck with fever, and the pain that usually occurs with eye movements. Head injury, which accounts for 4% of secondary headaches. This has many possible mechanisms, such as hemorrhage, hematoma, or direct injury to the brain. Vascular disorders occur in 1% of secondary headaches. An important disease in this etiology is the temporal or giant cell arteritis, which is an inflammatory disorder of arteries, affecting extracranial carotid circulation, and it is more common in the elderly with an onset age of 70. It is characterized by infrequent throbbing headache associated with polymyalgia rheumatica, jaw claudication, fever, and weight loss. It could be unilateral or bilateral, and it occurs in the temporal area 50% of the time. It also has scalp tenderness and is worse during the night and in the cold. It has reddening or red streaks of the skin overlying your temporal arteries. Subarachnoid hemorrhage has an incidence of less than 1%. It is characterized by acute severe headache, maximal in less than 5 minutes, but lasting for more than 5 minutes. It is associated with stiff neck, but unlike your meningitis, it has no fever. Its causes include ruptured aneurysm, AV malformation, and intraparenchymal hemorrhage. Brain tumors are rare causes of headaches, with only 0.1% prevalence. It is intermittent, deep, dull, moderate pain, which worsens with positional change or exertion. Other characteristics that may point out to the location or the type of tumors are vomiting for posterior fossa tumors, amenorrhea or galactorrhea in prolactin-secreting adenoma. If with known malignancy and de novo headache, it could be cerebral metastasis. If headache occurs abruptly after bending, lifting, or coughing, it could be from posterior fossa mass, Chiari malformation, or low CSF. Glaucoma is another possible source of headache, which is characterized by prostrating headache with nausea and vomiting. A prominent feature is a red eye, sometimes painful, with fixed mid-dilated pupils. The approach to patient with headache differs whether the headache is acute new onset or chronic daily or nearly daily headache. Acute new onset headache has a higher chance of having serious causes and will require rapid diagnosis and treatment. The following are headache symptoms that suggest serious underlying disorder: an onset headache, first severe headache, worst headache ever, vomiting preceding headache, subacute worsening over days or weeks, pain induced by bending, lifting, or cough, pain that disturbs sleep, present immediately upon waking, known systemic illness, onset after 55 years old, fever on unexplained systemic signs, abnormal neurologic imaging, or pain associated with local tenderness such as your region of the temporal artery. The diagnostic plan is as follows. First is a neurological examination, which includes palpation of cranial arteries, passive movement of the head to assess cervical spine, BP monitoring, and eye examination. Imaging like CT scan and MRI is helpful in identifying lesions in the brain. Lumbar puncture especially is important in infective etiologies unless a benign cause is found. Psychological examination helps to identify comorbidities associated with headache, such as depression and anxiety, but it does not identify the cause. It could also be helpful to have this since antidepressants are effective in preventing tension type and migraine headache. Thorough recent and past medical history can also help in IDing precipitating or aggravating events such as otologic or endodontic surgeries. Chronic daily headaches is defined as at least 15 days with headaches per month. Due to the persistence of symptoms, this results to considerable disability and reduces the quality of life. In the diagnosis, it is important to identify whether it's a primary headache or it has something with underlying cause. Primary headache causes of chronic daily headache are divided into more than 4 hours or less than 4 hours per day. The secondary causes of chronic daily headache are as follows. There are 2 diagnoses worth discussing, which includes your medication overuse headache and new daily persistent headache. For medication overuse headache, it is mostly due to prolonged use of analgesics for headache itself. This results to impaired effect of medication and induced refractory chronic daily headache. New daily persistent headache is a clinically significant syndrome that is characterized by abrupt headache on most days. Patients are also able to clearly recall the moment of onset, and it evolves over 3 days' time from the beginning of symptoms. Subcranial hemorrhage is the most serious cause for new daily persistent headaches. Other causes for NDPH, which includes primary and secondary headaches, are as follows. Let us discuss some secondary causes of importance in NDPH. Low CSF volume headache is described as occipitofrontal pain that begins while sitting or standing and is relieved by recumbency. It may be dull or throbbing, and it is not present when waking, but it progresses throughout the day and persists until the next day. The most common cause is a lumbar puncture, and it occurs within 48 hours to up to 12 days after the procedure. Other procedures include epidural injection and vigorous Valsalva maneuver. You can perform MRI with gadolinium, and it will show a diffuse meningeal enhancement and sometimes Chiari malformation. In spinal MRI, it may show CSF leak or cysts. Another cause for secondary NDPH is the raised CSF pressure, which may be from pseudotumor cerebri or a persistent raised ICP that triggers chronic migraine. It is described as a generalized headache present on waking and improves as the day goes, and is worse at recumbency. This is opposite of the first cause discussed, which is the low CSF volume. Due to the relations to ICP, visual symptoms such as obscuration and papilledema may be present. To confirm diagnosis, MRI with MR venogram and lumbar puncture may be performed. LP with improvement of symptoms after removing 20 to 30 ml of CSF may be diagnostic for this etiology. Lastly is the post-traumatic headache, which is a broad category ranging from head injury to prior infection. This may occur years after the insult to the pain-producing meninges. It also has dizziness, vertigo, and impaired memory. CNS imaging may be unremarkable due to the chronicity of the damage. In primary care setting, the main role of the physician is to identify the signs pointing out to serious causes of headache, as well as to diagnose and give initial treatment with follow-up. Specific treatment for CDH is of value to discuss. In medically intractable disabling primary CDH, if the patient does not respond to analgesic and lifestyle modifications, two options are available. First is your monoclonal antibodies to calcitonin gene-related protein. It is effective in chronic migraine. Second is your non-invasive neuromodulatory approaches, which includes your single-pulse transcranial magnetic stimulation and non-invasive vagal stimulation. Both aims to modulate your thalamic process or brainstem mechanism to prevent headaches. Medication overuse headache is divided into two managements. First is for outpatient management, which focuses on limiting exposure by tapering the drug to less than 10% every 1 to 2 weeks. The patient may use naproxen 500 mg orally twice a day for pain management. NSAIDs taken only twice daily does not have any negative effect on the pain pathway. Preventive medications, which may be added later in the management, will not work until the offending analgesic is removed. Inpatient management is more on the detoxification of the patient, with complete removal of the analgesic and supporting antiemetic and fluid therapy. Clonidine may be given for those having opioid withdrawal syndromes. Residual pain may be managed with IV aspirin 1 gram. For remission, ergot alkaloid IV DHE every 8 hours for 5 days may be given. Management for NDPH differs for the cause. For low CSF volume headaches, you need to have the patient in bed rest with IV caffeine 500 mg in 500 ml of saline over 2 hours for 2 infusions. Abdominal binder may be used when standing or sitting, and theophylline may be given for intractable pain. For raised CSF pressure, carbonic anhydrase inhibitor acetazolamide is used to lower CSF production. Topiramate is a second line of treatment. ICP monitoring and CSF shunting may be done for severely disabled cases. During the initial patient contact, if the headache does not initially respond to appropriate management, follow-up is important to monitor the progression of headache and to have a better diagnosis. This is an algorithm that summarizes the approach to patients with headache. Here is my reference. Thank you, and please subscribe to my channel.